One of the near-death experience cases documented by Dr. Elisabeth Kübler-Ross in her files at the University of Chicago Hospital starts on a cold morning in March 1976. By that time, the Swiss psychiatrist had already established her practice of clinical observation of terminally ill patients in the medical facilities of the Illinois region, applying her strict methodology to what she referred to as the final stage of life. The hospital, with its characteristic green linoleum hallways and yellowish fluorescent lighting of the 70s, maintained an atmosphere of clinical efficiency that was a sharp contrast to the profound phenomena the doctor was about to witness. Thomas Reynolds was a 46-year-old man, a railroad worker by trade, who labored on the lines that crisscrossed Chicago's industrial suburbs. His routine involved long shifts inspecting tracks and supervising cargo, a life of manual labor that had shaped his sturdy physique and calloused hands. Married for 23 years and a father of 2 teenage children, Reynolds represented the average American worker of that decade, a man without a college education but with deep dignity in his profession. Dr. Kübler-Ross would later note in her records that he was a pragmatic individual with no apparent mystical leanings or significant involvement with religious practices beyond the occasional Sunday visits to the neighborhood Lutheran church. The incident that would change Thomas Reynolds' life path occurred on the morning of March 18th, when an accident at the Blue Island Railway Station resulted in severe chest trauma. A metal beam detached from a freight car during maintenance operations, hitting Reynolds with enough force to fracture multiple ribs and puncture his right lung. The paramedics who treated him recorded unstable vital signs during the ambulance transport, with his blood pressure progressively dropping and his breathing becoming increasingly labored. Upon arrival at the University of Chicago Hospital at around 10:15 in the morning, the patient was immediately rushed to the operating room for emergency surgery. Dr. Samuel Green, a thoracic surgeon with 15 years of trauma experience, led the medical team that morning. Operating room number 3, where the procedure would take place, was equipped with the technological resources available at the time. A direct current defibrillator with metal paddles, an ambu-type manual mechanical ventilator, analog heart monitors with continuous paper tracings, and the standard pharmacological arsenal that included injectable adrenaline, lidocaine, and sodium bicarbonate. Nurse Margaret Hill, an experienced assistant who had worked with Dr. Green for 8 years, prepped the room according to the strict protocols of the era, checking every sterilized surgical instrument and organizing the metal trays with methodical precision. The surgery began at 11:05 with the goal of repairing the pulmonary laceration and draining the hemothorax that was compromising the patient's breathing capacity. For the first 30 minutes, the procedure went as expected, with the surgeon methodically working to control internal bleeding and stabilize the damaged structures. Dr. Kübler-Ross, who had been invited by the psychiatry department to observe cases relevant to her studies on death and dying, was present in the observation gallery above the operating room, taking notes in the black-covered notebook that was her constant companion during her field research. At 11:42, the heart monitors began to emit the sharp, continuous sound that signaled cardiorespiratory arrest. The electrocardiographic tracing, which had previously shown a normal sinus rhythm, transformed into a nearly flat line with only small, irregular undulations indicating ventricular fibrillation. Dr. Green immediately halted the surgical procedure and began cardiopulmonary resuscitation protocols. Nurse Hill would later record that the surgeon maintained a remarkable professional calm, barking clear orders while initiating chest compressions directly on the exposed heart through the surgical incision, a technique of internal cardiac massage possible due to the nature of the ongoing surgery. The first electrical shock was applied at 11:43 with the defibrillator set to 200 joules. The metal paddles were positioned with conductive gel, and Thomas Reynolds's body briefly arched under the impulse of the electric current crossing his chest. The heart monitor showed no significant change, maintaining the fibrillation pattern that indicated the absence of effective circulation. Nurse Hill prepared the dose of adrenaline according to protocol, 1 milligram diluted in 10 milliliters of saline solution, administered through the central venous access that had been established before the surgery. Dr. Green continued the direct manual compressions on the heart muscle, feeling the flaccid texture of an organ that had ceased its vital function under his gloved fingers. The second shock was delivered 30 seconds later, again with 200 joules. Dr. Kübler-Ross observed from the upper gallery, her notebook open, but her notes interrupted by the tension of the moment. She would later describe those minutes as a suspension of ordinary time where the border between life and death became not merely conceptual, but viscerally real. The electrocardiogram tracing continued to show the irregular line of fibrillation, and the clock on the operating room wall marked 11:44. The medical team worked in silent synchronization, each member executing their function with the precision born of experience, yet all conscious that every second of clinical death reduced the probabilities of full neurological recovery. It was at 11:45 that the cardiac monitor began to show changes. First an isolated contraction, then another, and finally the gradual return of a rhythm that, although irregular, indicated spontaneous cardiac activity. Dr. Green maintained compressions for a few more cycles before allowing the heart to fully take over its function. The blood pressure, which had dropped to unmeasurable levels, began to recover slowly, first 50/30, then 70/40, eventually reaching 90/60. The oxygen saturation in the blood, monitored through an analog reading device connected to the patient's finger, began its ascent from critical levels to safer ranges. The medical record would document that Thomas Reynolds had remained in a state of clinical death for exactly 3 minutes. The surgery was completed over the next 2 hours, with Dr. Green finishing the lung repair and chest closure with meticulous suturing. The patient was moved to the intensive care unit, where he would remain under constant observation for the first 24 hours post-operation. His vital signs progressively stabilized, and preliminary neurological exams showed no evident brain damage, although the complete prognosis could only be determined after the patient woke up. Dr. Kübler-Ross visited the intensive care unit that afternoon, spoke briefly with the medical staff, and recorded her initial observations of the case in her notebook, not yet imagining that this would become one of the most significant accounts in her extensive research on near-death experiences. Thomas Reynolds remained sedated for the first 36 hours after the surgery, a standard protocol to allow the body to begin the recovery process without the added stress of consciousness. When the sedatives were gradually reduced on the morning of March 20th, the medical team carefully observed his progressive return to consciousness. His pupils responded adequately to light, his reflexes were preserved, and his breathing, though still partially assisted by mechanical ventilation, showed increasing effort on his own. At around 10 o'clock that morning, Reynolds opened his eyes, initially disoriented as expected, but gradually focusing on the environment around him with an expression of recognition. It was the next day, March 21st, that the extraordinary account began to surface. Dr. Green was making his routine morning rounds when Thomas Reynolds, now more alert and able to hold a conversation, made an observation that immediately captured the surgeon's attention. Reynolds said he remembered seeing the operating room from above, as if he were floating near the ceiling, watching the entire medical team working on his body. The surgeon, a man of strict scientific training and naturally skeptical of accounts that didn't fit conventional physiological explanations, was about to attribute the comment to hallucinations induced by cerebral anoxia when Reynolds provided a specific detail that made him pause. The patient described seeing a blue adhesive tape on the operating room floor, near the instrument cart, and mentioned that the clock on the wall was marking nearly noon when his heart stopped. Even more striking, Reynolds commented on the sweat on Dr. Green's face, saying he had watched beads running down the surgeon's forehead during the resuscitation efforts. The doctor remained silent for a moment, processing the information. He distinctly recalled the blue adhesive tape that had fallen from one of the pieces of equipment during the procedure, a trivial detail that certainly wasn't in any medical record. As for the sweat, that was verifiable through his own memory. The room was particularly warm that morning, and the resuscitation efforts had been physically strenuous. Dr. Green decided to immediately notify Dr. Kübler-Ross about the case development. He was familiar with her work on terminal patients and was aware that she maintained a particular interest in accounts of near-death experiences, though he himself maintained reservations about the nature of these phenomena. The doctor arrived at the hospital that afternoon, carrying her characteristic brown leather satchel filled with notes and her magnetic tape recorder, a bulky piece of equipment by modern standards, but considered cutting-edge technology for qualitative research at the time. She was escorted to the room where Thomas Reynolds was recovering, a simple space with light beige painted walls, a window overlooking the hospital parking lot, and the constant mechanical sounds of the medical monitors. Dr. Kübler-Ross introduced herself with the gentleness that was her trademark in patient interactions. She pulled a chair close to the bed, positioned the recorder on the side table after asking permission to record the conversation, and opened her notebook. Her first questions were deliberately open-ended, allowing Reynolds to tell his experience in his own words without direction or suggestion. She adopted this methodology in all her interviews, deeply believing that the most authentic narratives emerged when patients felt truly listened to instead of interrogated. Reynolds, initially hesitant about sharing something he himself didn't fully comprehend, gradually relaxed under the psychiatrist's attentive and non-judgmental listening. The account that emerged during that March afternoon transcended the brief descriptions Reynolds had offered to Dr. Green. He described that, the moment he realized he was observing the operating room from above, he felt no panic or fear, but a strange serenity. His visual perception was extraordinarily clear, sharper than his normal vision, he said, and he could see details that seemed impossible given the distance and angle. He observed every member of the medical team, noted the tension in their movements, and said he felt particular compassion for Dr. Green, sensing the weight of responsibility the surgeon carried in those critical moments. Then came what Reynolds described as a transition, although he struggled to find adequate words for the phenomenon. He said his perception of the operating room began to dissolve, not abruptly, but gradually, as if he were being gently led to another state of consciousness. He described a sensation of movement through what he called a welcoming darkness, not a threatening darkness, but a comforting one, as the maternal womb might be to a consciousness that could perceive it. Dr. Kübler-Ross methodically took notes, occasionally asking clarifying questions, her expression remaining neutral so as not to influence the account, but her eyes revealing the deep interest such narratives always sparked in her. Thomas Reynolds' description of what he next experienced featured elements that Dr. Kübler-Ross recognized from other cases she had documented, but also particularities unique to his individual experience. He spoke of a light that started as a distant point and progressively grew, but said that describing this light as merely bright was inadequate. Reynolds struggled with language, explaining that the light possessed a quality of presence, as if it were simultaneously a source of illumination and a conscious being. It didn't hurt his eyes, he insisted, despite being more radiant than anything he had seen in earthly life. The light seemed to contain within it a sense of unconditional love, a complete acceptance that transcended judgment. During the experience, Reynolds reported perceiving the presence of what he described as beings or entities, though he admitted those terms were imperfect approximations of what he truly felt. They were not figures with a defined physical form, but discernible presences, each emanating distinct individuality despite the absence of material bodies. One of these presences, he said, communicated with him not through spoken words, but by means of a direct transmission of meaning that he received as instant comprehension. The message was that he could not remain in that state, that he had unfinished work in his earthly life and needed to return. The life review Thomas Reynolds described was not a simple sequential recollection of events, but something far more complex and multidimensional. He said he simultaneously experienced multiple moments of his existence, perceiving not only his own actions and thoughts, but also the impact of those actions on other people. He saw with penetrating clarity moments when he had been kind and moments when he had been negligent or cruel. But what impressed him most was that the experience was not accompanied by external judgment. Instead, it was he himself who recognized where he had acted in alignment with love and where he had failed, feeling the pain he had caused others as if it were his own pain. After what seemed simultaneously an instant and an eternity, Reynolds described the return to physical consciousness as a violent and disorienting process. The clarity and expansion he had experienced on what he called the other side contrasted brutally with the limitations of being confined to a body again. He recalled intense pain, the difficulty of breathing, the feeling of weight and density of physical matter. But along with these uncomfortable sensations came something new, a radically altered perspective on the meaning of his existence. Death, which had previously been an abstract but persistent fear somewhere in the back of his consciousness, had transformed into something different through direct experience. Dr. Kübler-Ross conducted several additional sessions with Thomas Reynolds during his hospital stay and in the following weeks after his discharge. She applied her characteristic methodology, asking detailed questions, looking for inconsistencies in the account, exploring possible physiological or psychological explanations for each element of the experience. Reynolds was consistent in his details across multiple interviews, an indicator the doctor considered significant when evaluating the phenomenological authenticity of near-death accounts. She observed that patients who fabricated or exaggerated narratives tended to add new elements or contradict previous details when questioned repeatedly, while those reporting genuine experiences maintained essential consistency even when describing aspects they themselves didn't fully comprehend. It was in April 1976, approximately 1 month after his hospital discharge, that Thomas Reynolds returned to the University of Chicago Hospital for a psychological follow-up consultation with Dr. Kübler-Ross. The office where she received patients was a modest space on the 3rd floor of the main building, with a dark wooden desk, 2 upholstered chairs in the brown fabric characteristic of the era, a bookshelf with books on psychiatry and thanatology, and a single window that offered a view of the hospital's inner courtyard. The afternoon spring light entered obliquely, creating an atmosphere of quiet reflection. Reynolds arrived promptly at 3 o'clock, wearing a checkered shirt and work pants, his face showing complete physical recovery, but his eyes revealing a different restlessness than in previous sessions. Dr. Kübler-Ross greeted him with her usual welcome, indicating the chair where he should sit, while she positioned herself in her own chair with the notebook on her lap. She observed that Reynolds seemed physically restored, his breathing normal, his movements without the caution that characterized patients still recovering from chest surgery. But there was something in his posture, a hesitation in the way he settled into the chair that indicated he brought something significant to share. The doctor waited in silence, allowing the patient to find his own words in his own time, a technique she considered essential to allow authentic narratives to emerge without direction or external pressure. Reynolds began by talking about his adjustment to daily life after returning from the hospital, the minor physical challenges that still persisted, the gradual resumption of normal activities. But then he paused, his fingers nervously intertwining, and said there was something else he needed to mention, something that had been happening since he came home and that he didn't know how to interpret. Dr. Kübler-Ross leaned slightly forward, her gaze attentive but not intrusive, and encouraged him to continue. Reynolds took a deep breath and said he was having dreams, not the common, fragmented dreams he had always had throughout his life, but dreams of extraordinary clarity and vividness, dreams that seemed more real than memories and that left him profoundly unsettled upon waking. He described that in the dreams he saw himself working, but not on the Chicago railways where he had spent more than 2 decades of his life. Instead, he found himself in environments he didn't recognize with his waking mind, but that felt deeply familiar during the dream. He worked with tools that weren't the modern tools he knew, simpler, more rudimentary implements, hand-forged, heavy and worn from use. His hands in the dreams were calloused differently, marked by another kind of labor, and he wore clothes that didn't belong to the 20th century, coarse, dark fabrics, the attire of a worker from another era that he couldn't precisely identify. The most unsettling thing, Reynolds explained to Dr. Kübler-Ross, was the feeling that the worker in the dreams was himself, not another person, not an imaginary character, but him, Thomas Reynolds, living a life that his waking consciousness insisted was impossible. He saw himself digging earth, constructing stone structures, working under a sun that seemed more intense than the Illinois sun. There were other people in the dreams, faces he didn't recognize but with whom he felt a deep connection, as if they were family or longtime companions. He heard voices speaking words he didn't fully understand, but whose general meaning penetrated his dream comprehension. And always, permeating everything, there was a sense of purpose, of doing important work, even if humble, of living a life that had meaning within its own terms. Reynolds looked directly at Dr. Kübler-Ross and said, in a voice that mixed confusion and conviction, that it was as if he were remembering something he had lived, but not in this life, not in the existence he knew as Thomas Reynolds, born in 1930 in Chicago. He immediately rushed to add that he didn't believe in reincarnation, that his Lutheran upbringing and his pragmatic disposition made him skeptical of such concepts, but that he couldn't find any other language to describe the peculiar quality of these dreams. They were not fantasies or free imagination. They didn't have the fragmented, surreal texture of normal dreams. They possessed narrative coherence, temporal continuity, and a sense of lived reality that persisted even after waking up. Dr. Kübler-Ross listened without interruption, her face maintaining the neutral expression characteristic of her clinical practice, but her eyes revealing the deep attention she dedicated to every word. When Reynolds finished, she remained silent for a few moments, allowing the weight of the account to settle in the space between them. Then, in the calm and non-judgmental voice that was her trademark, she began to ask clarifying questions. How often did the dreams occur? Was the content always similar, or did it vary significantly? Were there specific emotional elements associated with the dreams? How did he feel upon waking up? The questions were clinical but not cold, investigative but not intrusive, designed to map the phenomenon without imposing premature interpretation. Reynolds replied that the dreams happened approximately 3 to 4 times a week, always during the deep hours of the night. The content varied in specific details but maintained consistent themes: manual labor, rural or semi-rural settings that seemed pre-industrial, a sense of community with people he didn't know in his current life, but who were intimately familiar in the dreams. Emotionally, the dreams were neutral or even positive during the experience. There was no terror or anguish, just the texture of daily life being lived with its ordinary difficulties and satisfactions. But upon waking, he felt a strange melancholy, a sense of loss or longing for something he couldn't name, as if he were being separated from an existence that was genuinely his but remained inaccessible except through these dream fragments. Dr. Kübler-Ross carefully recorded this information in her notebook, her precise handwriting filling the pages with clinical observations and direct quotes from the patient. She then offered a preliminary interpretation, emphasizing that it was only one possibility among several and that the ultimate nature of the phenomenon remained uncertain. She suggested that the dreams could be part of the psychological reorganization process following the trauma of clinical death and the near-death experience. The brain, having gone through an extreme state of anoxia and subsequently a subjective experience of profound transformation, might be processing and integrating these experiences through dream narratives. The images of past lives or alternative existences could be symbolic constructions that the psyche created to make sense of the feeling of continuity of consciousness that Reynolds had experienced during the 3 minutes of clinical death. Alternatively, the doctor continued, maintaining her carefully neutral tone, there were philosophical and religious traditions in multiple cultures that postulated the continuity of consciousness through multiple existences. She was not in a position to affirm or deny the validity of these traditions, as they transcended the domain of empirical scientific investigation as she practiced it. What she could observe clinically was that near-death experiences frequently produced changes in patients' perceptions about the nature of consciousness and identity, and that vivid dreams following such experiences were not uncommon in her practice. Some patients reported dreams of deceased loved ones, others of scenarios that seemed to transcend their current life experience, and these phenomena deserved careful documentation regardless of their ultimate interpretation. Reynolds listened attentively and then said something that Dr. Kübler-Ross would record in her notes as particularly significant. He said that regardless of what the dreams actually were, whether genuine memories of previous existences or complex psychological elaborations, they had changed something fundamental in his perception of himself. He no longer saw himself as simply Thomas Reynolds, a railroad worker from Chicago, living a single, linear life between birth and death. Instead, he began to perceive his identity as something vaster and more mysterious, a consciousness that perhaps existed in dimensions that transcended the specific biography of this particular life. And curiously, this expanded perception did not leave him anxious or disturbed, but rather profoundly at peace, as if he were recognizing something that had always been true, but that he hadn't had the language to articulate before the experience in the operating room. Dr. Kübler-Ross thanked Reynolds for sharing these experiences with honesty and courage. She emphasized that there was nothing pathological in the phenomena he was reporting, that he didn't need to fear losing touch with reality. On the contrary, she saw his accounts as indicative of a healthy psyche processing extraordinary experiences creatively and integratively. She encouraged him to continue recording the dreams if he felt inclined, not with the goal of proving them or analyzing them excessively, but simply as a way to honor and give space to the experiences his consciousness was generating. She scheduled another follow-up session for the following month and walked Reynolds to the office door, watching him walk down the hallway with firm steps and a serenity that wasn't present in his previous visits. After his departure, Dr. Kübler-Ross returned to her desk and opened her notebook again. She wrote a detailed clinical observation about the session, documenting the specific elements of the reported dreams, the patient's emotional reactions, and her own preliminary interpretive hypotheses. In the bottom margin of the page, she added a personal note, separate from the formal clinical documentation, where she wrote, "Possible symbolic representation of the continuity of consciousness after clinical death. Dreams as a bridge between transcendent experience and psychological integration. Question remains. Are they constructs of the mind or memories of something genuine? Impossible to determine with certainty, but phenomenologically significant regardless of the ontology." She closed the notebook slowly, her gaze lingering on the window where the afternoon light was beginning to take on the golden tone of the day's end. Thinking of the vast depths of human consciousness that her work continually revealed and that remained, perhaps necessarily, shrouded in mystery. The scientific analysis that Dr. Kübler-Ross conducted on Thomas Reynolds' case followed the strict standards she applied to all phenomena related to death and dying. In her notebooks, she systematically explored the conventional physiological explanations that could account for the reported elements. Cerebral anoxia, the oxygen deprivation in the nervous tissue during the 3 minutes of clinical death, was the first hypothesis to be considered. Neurological research at the time already showed that the brain in a state of severe hypoxia could produce vivid hallucinations, sensations of disconnection from the body, and altered perceptual experiences. The massive release of neurotransmitters like dopamine and serotonin in response to the extreme stress of imminent death could also theoretically explain the sensations of well-being and the luminous perceptions described by many patients. But even while acknowledging the validity of these lines of investigation, Dr. Kübler-Ross was faced with elements that resisted complete reduction to conventional explanations. The verifiable information Reynolds provided about the operating room constituted what she called in her notes, persistent anomalous data. How could a patient under deep anesthesia, with a brain in a state of severe anoxia undergoing open-chest surgery, have visual access to trivial but verifiable details of the environment? The blue adhesive tape, the surgeon's sweat, the exact time on the clock, these were not elements that could be deduced or guessed. They were specific, mundane, and confirmed by multiple independent witnesses. The most dramatic change came a few months after his recovery, when Thomas Reynolds made the decision to quit his job at the railway. He had worked on the tracks for 23 years, since he was 20 years old, and it was a job that provided reasonable financial stability for his family. But Reynolds felt that the near-death experience had revealed something fundamental about the purpose of his existence, and continuing in a job he performed purely out of economic necessity no longer aligned with that understanding. He began volunteering in one of the first hospices being established in the Chicago area, institutions dedicated to the compassionate care of terminally ill patients, a movement of which Dr. Kübler-Ross herself was a pioneer and passionate advocate. At the hospice, Reynolds discovered a vocation he didn't know he possessed. His work consisted of spending time with patients who were in the final stages of terminal illnesses, offering human presence, attentive listening, and practical comfort. He had no formal training in palliative care or psychological counseling, but he possessed something that no training could provide: direct experiential knowledge that death was not a terrifying end, but a natural transition. This certainty, born of his own experience, was transmitted to terminally ill patients in a way that words alone could not achieve. He became particularly effective at helping patients who struggled with intense fear of imminent death, his calm presence and careful accounts of his own experience offering genuine comfort. In November 1977, Dr. Kübler-Ross presented the case of Thomas Reynolds, meticulously anonymized to protect the patient's privacy, at an international symposium on death and dying held in Boston, Massachusetts. The event gathered physicians, psychologists, theologians, philosophers, and researchers from various disciplines interested in the scientific, ethical, and spiritual dimensions of the end of life. The doctor's presentation was scheduled for the symposium's second day in a university hospital conference room hosting the event, a space with upholstered seats arranged in ascending rows and a slide projector at the front, technology considered modern for academic presentations at the time. Dr. Kübler-Ross delivered the case using her characteristic approach, balancing scientific rigor with humanistic sensitivity. She described the precise medical circumstances of the accident and surgery, the 3 documented minutes of clinical death, and the resuscitation procedures used. She then shared elements of Reynolds's account, emphasizing both the deeply personal subjective aspects and the verifiable objective details that defied conventional explanations. Her presentation included an analysis of possible physiological and psychological explanations, demonstrating that she had carefully considered standard scientific alternatives before suggesting that the phenomenon warranted deeper investigation that transcended simplistic reductionism. The discussion that followed the presentation extended far beyond the allotted time, with participants sharing their own cases, proposing research methodologies, and debating the philosophical and practical implications of near-death experiences. A psychiatrist from the University of Virginia mentioned he was beginning to systematically collect similar accounts. A hospital chaplain described how terminally ill patients often reported visions of deceased loved ones days or hours before their own death, experiences he had initially attributed to delirium, but now questioned whether they might have another dimension. A philosopher raised questions about the nature of evidence in domains where controlled experimental replication was impossible, but experiential testimony was abundant and consistent. In 1978, Dr. Kübler-Ross took her findings to international audiences, presenting at medical conferences in Geneva, Switzerland, her hometown, and in London, England. The European presentations found particular receptivity in Switzerland, where philosophical and psychological traditions influenced by Carl Jung had created a greater openness to phenomena that transcended materialistic reductionism. In London, she presented at the Royal College of Physicians, an institution with centuries of medical history, where her message that medicine needed to recover a humanistic and spiritual dimension in the care of terminally ill patients resonated with doctors who felt uncomfortable with the growing technologization and dehumanization of modern medical practice. During one of these international trips, in April 1978, Dr. Kübler-Ross received a letter from Thomas Reynolds. She was in her London hotel room reviewing notes for a presentation the next day when she opened the envelope with a Chicago postmark. The letter, written in careful handwriting but clearly unaccustomed to formal correspondence, began with thanks for the patience and attention the doctor had shown during the interviews following his near-death experience. Reynolds wrote that more than 2 years had passed since the incident in the operating room, and that time had confirmed rather than diminished the transformative impact of the experience. He described his work at the hospice with details that revealed a deep sense of purpose and fulfillment. Reynolds wrote about specific patients he had accompanied through their final weeks of life, the conversations they had, the fears he had helped alleviate, the genuine human connections that had formed even, or especially, in the imminent presence of death. He mentioned that several patients had confided their own visionary experiences near death, encounters with luminous figures, perceptions of deceased loved ones, sensations of peace that transcended their physical suffering. He felt honored to witness these experiences, to be able to reassure patients that what they were experiencing was real and valid, regardless of how it was interpreted. Reynolds concluded the letter by expressing deep gratitude for having been heard seriously and respectfully, without judgment or attempts to reduce his experience to pathological categories. He wrote that Dr. Kübler-Ross's work in legitimizing the experiences of dying patients and giving a voice to those society preferred to silence was of immeasurable importance. He signed the letter simply, Thomas Reynolds, Chicago, Illinois, with the date April 18, 1978. The doctor held the letter for a long time after finishing it, watching the London evening light filter through her hotel room window, feeling the weight of the responsibility her work carried and also the profound satisfaction of knowing that it made a tangible difference in real human lives. That night, before sleeping, Dr. Kübler-Ross opened her personal reflection notebook, separate from her formal clinical notes, and wrote an entry about Thomas Reynolds' case and its significance within the broader context of her research on death and dying. She wrote that what Reynolds had experienced, regardless of its ultimate ontological nature, was not proof of life after death in the traditional theological sense. It did not demonstrate the existence of heaven or hell, did not validate any specific religious doctrine, did not solve the fundamental mysteries of consciousness and existence. What the experience offered, she wrote, was something simultaneously more modest and more profound, an invitation to humility before the mystery of dying, a recognition that human consciousness in its extreme states could access dimensions of experience that conventional science did not yet adequately understand. Now that you've come this far, I want to invite you to participate. Share in the comments below. Have you ever had, or do you know someone who went through a near-death experience? What did this story of Dr. Elisabeth Kübler-Ross and Thomas Reynolds awaken in you? What reflections did this account bring about your own life, about the fear of death, about what truly matters in the time we have here? The comments on this channel are a lively space for exchange, a place where people from all over the world connect through scientific knowledge, personal growth, and the quest to better understand the mysteries of human existence. Who knows? Maybe someone who studies the same subject as you, who is interested in the same deep questions about consciousness and transcendence, lives right near your city. These real connections happen here every day because we believe that shared knowledge is multiplied knowledge. So take advantage and be part of this community. Subscribe to the channel if you haven't already, because every week we bring new documented cases, new stories that challenge our understanding and invite us to look at life and death with more depth and less fear. Comment below what city you're watching from, build those bridges, talk with other people in the comments. Who knows, a true friendship might be born from here. And if this video touched your heart, if the story of Thomas Reynolds and the pioneering work of Dr. Kübler-Ross made you see something differently, share it with someone special, a friend, a family member, someone who is also seeking answers to these fundamental questions. Together, we create a network of people committed to knowledge, compassion, and the courage to look directly at the mysteries that define us as human beings. Thank you for being here, for being part of this journey, and see you in the next video, where we'll continue exploring the frontiers between science and mystery, always with rigor, always with humanity.